Shall we open it to questions then? Senator McIntyre, can I ask you to lead?
Thank you, Mr. Kroon, for your presentation. How do you think the legalization of recreational marijuana will affect veterans' use of medical marijuana? Do you anticipate that people could self-medicate using recreational cannabis without appropriate medical follow-up? Because I think follow-up, keep bearing in mind your presentation, is extremely important.
Absolutely. No, it's a great question. We hope and certainly will encourage all veterans to continue to go through a medical process relative to their cannabis use for PTSD or chronic pain and other conditions. As you've indicated, it's extremely important to fine-tune the treatment. Again, it's never simply just about one strain of cannabis. There's different uses during the day and the evening. There is some experimentation that needs to occur. And therefore, in terms of having ongoing clinical assessments, ongoing renewals, it is very important that it continues to go through a separate medical process. Riley, I don't know, as a veteran yourself, if you have anything to add to that, but it is extremely important that the medical process continues for veterans.
We see the medical and the recreational very separate, and I think the service offering that we have at the clinics is very conducive to what a veteran needs to heal and improve their lives with cannabis. So I think the veterans will continue to seek cannabis through a clinical platform like ours.
Okay. I have a question regarding gender issues. Approximately what proportion of your customers are women? And more specifically, what proportion of your customers who are veterans are women? And are there indications that cannabis could act differently on men and women?
So certainly the veterans, I don't have the specific number, but obviously, would skew more male than female. Outside of our veterans, we have slightly more Canadians we work with than veterans, and quite a few of those are seniors. Again, it's a range of different ages depending on the conditions, but I would say outside of veterans, it would be fairly split evenly as the proportion of population. I don't know, Riley, if you've got any further indication on that.
It's difficult to say without going back to our database to actually give you exact numbers, which we could do. I think what's important is that we validate medical patients on a software platform that helps us to understand exactly that and track exactly that, to know whether it's affecting women differently than men, what strains are tied to what conditions and improvements, and really start to understand the science behind cannabinoid therapy, which a platform that validates the patient, gives them a recommended treatment protocol, and tracks the cannabis they're actually using to treat what condition. When we're using a software platform like that, we'll finally be able to provide the evidence that I think physicians and Veterans Affairs Canada, the medical community, has wanted for decades now. And until we can kind of all cooperate and collaborate and bring medical patients onto this type of platform, I think that evidence will continue to elude us.
And I do believe, again, we use nurses as our cannabinoid therapy experts, and they certainly look at everything in terms of, obviously, the medical condition. I suspect they would be looking at sort of gender, because obviously, similar to alcohol, there are some differences in terms of impact on male and female, so there definitely are some differences there. They'll look at elements where, if someone was a cannabis user previously recreationally versus someone who hasn't been, that is factored into their recommendations as well. So the key is, in our view, that you have a patient-specific cannabinoid treatment plan, which looks at medical history, condition, diagnosis, usage in the past, what they are doing sort of day and evening, need to drive, need to work, all those different elements. So I think the most important element is this idea that it has to be a patient-specific treatment plan.
I would have another question regarding the impact of legalization of recreational marijuana. Mr. McGee, I understand you're a licensed cannabis producer?
That's right.
Okay. So my question would have to do with the medical market versus the legal recreational market. As you know, licensed producers, well, according to the media, are experiencing shortages of cannabis. As a result, patients using medical cannabis are apparently having trouble obtaining the product because their producers are now supplying the legal recreational marijuana. Are cases of patients using medical cannabis who cannot resupply themselves widespread or isolated?
I'm hoping that it's a temporary issue. I think there's certainly some producers that are focused more on the recreational market, so there will be less product available to their medical patients. Many of the other producers that are struggling with providing their medical patients with cannabis right now, I think a lot of it boils down to the CRA registrations and the excise duty tax stamps that are required, as well as the new packaging laws. So a lot of licensed producers, as of October 17th, had problems keeping inventory on their websites based on repackaging and applying these excise duty tax stamps. So I do expect that more medical cannabis will be coming online, and already has in a lot of cases. Right now, we're not getting widespread complaints about unavailability of product for our medical patients. Most of the licensed producers, as long as they can get the packaging and the excise duty tax stamps right, do still have product available for their medical patients.
If I could just add, I mean, medical cannabis patients, unfortunately, over the years have experienced issues well before legalization in terms of supply as the industry has ramped up production. Again, that's why, working through a clinic, we often end up recommending, and this has been a practice for years, having people split their script between multiple licensed producers just to kind of hedge the bets a little bit. We're hoping that as we kind of get through this adjustment, and obviously there's a lot of production that's coming online in Canada, that, as Riley indicated, hopefully it's a short-term issue because, frankly, this is real medicine. People are very dependent on it, and it's a significant issue if someone doesn't have their medicine.
In order to avoid any, I'm sorry, Mr. McGee, go ahead.
I do think that the way the industry is structured right now, licensed producers are appropriately incentivized to provide product to the medical patients as they can retail directly to those patients. So I do think that the revenue model supports the support of medical patients from a licensed producer perspective.
In order to avoid any problems, do you believe that Health Canada should set quotas to require licensed producers to allocate some of their production to the medical market?
I think it's a great idea. That's something that we've discussed before. I think that the logistics of that could be challenging. Licensed producers deal with things like crop losses and other challenges that maybe traditional pharmaceutical producers would not. So mandating inventory levels and things like that could be great for the medical user, could be challenging for licensed producers in some instances, but I think that if it's something that could be done even-handedly and fair, I think it's definitely something that should be done. And if LPs are going to commit and take on medical patients, they should commit to having the appropriate medicine for those patients on hand.
So this is one of the recommendations, or one of the recommendations you would make to the federal government?
Yes.
Yeah.
Yes.
Okay. Mr. McGee, you've mentioned the excise tax.
Yes.
This subcommittee has heard that since recreational marijuana was legalized, the excise tax applies to all cannabis products, both recreational and medical. How has the excise tax in effect since October 17 affected veterans who use cannabis for medical purposes?
Some of the licensed producers are covering the cost of that excise duty tax stamp and not flowing that through to veterans. Other licensed producers are. So in some cases it has raised the cost of the cannabis for veterans above and beyond the $850 covered by Veterans Affairs Canada, and they have to top that up personally. Other licensed producers have absorbed that and are not forcing veterans to make those extra payments. I guess personally, watching this industry unfold, I can understand the reason for putting an excise duty stamp on all product, both medical and recreational, based on the fact that in the past couple of years, I think there are a substantial amount of people who have utilized the medical market to access cannabis for recreational purposes, essentially. And I think that's one of our goals of our group, is to really validate the medical patient and put processes in place that make it, these are true medical patients. We don't have to worry about that crossover. And now that the recreational market is here, I'm hoping that we can kind of work together to define what a validated patient process is. And once we can validate those medical patients, we're in a position to hopefully remove the excise duty tax stamp from the medical regime, where I don't necessarily think it's appropriate long term, but I can understand why it was implemented out of the gate until we kind of shake things out and differentiate between these two markets.
We can move to Senator Richards.
Yes.
Okay. Thanks very much, and thanks for your service, and thanks for your presentation. I'm wondering how many NATO countries have medical marijuana as a as help for veterans? You know, like does Australia, New Zealand, are they on board with this? And Norway, are they on board with this? Do you know how many?
Several are looking at it and researching it.
Yeah.
It is my understanding, I could be incorrect on this, I don't know this for sure, but it's my understanding that Canada is currently the
only one?
As far as I understand, that's covering 100% of the medical cannabis
Okay.
for veterans, which we're very grateful
Sure.
for.
That's strange, isn't it? I think that's a little strange. That
I think
other
it's
countries-
I think it's forward thinking, and I think it's
Yeah.
I think the results we're getting are excellent, and I think the rest of the world is looking at Canada
Yeah,
for
no,
how we
what I mean is it's strange that other countries haven't come on
Oh,
board.
yes,
Yes.
absolutely. Sorry,
That's
I
what
thought
I
you were saying
mean.
it's strange that we were.
Yeah. No, not strange.
yeah,
no.
yeah.
But there, and people, when I ask this question, think that I'm against this, and I'm not at all. I just have two friends in hospice who use medical marijuana on a daily basis, and I understand how it helps people. But it's not a cure-all.
No.
And then that's
Right.
and that's my main question, because it's not a cure-all, and there are different strains which react with different people, and I'm wondering how we can figure this out so people don't become harmed by it if they get the wrong strain and have a psychotic event or whatever. I'm just wondering how much research goes into finding the strains that actually work for the greatest number of people, or is it a chance that you're taking?
Sorry.
Let me start, and then Riley definitely has a lot of experience on this as well. I mean, it's an excellent point, and we feel strongly about this. If anything, there probably should be more regulation relative to the clinic side of the industry to, again, have that you've only got well-trained, experienced kind of medical people who are recommending particular strains. And so in our case, we have 10 clinics across Canada. We've got years of experience, and so we share information amongst those educators that indicates what has worked for different conditions for different patients. The most important element is that we have this database in terms of tracking, what pharmaceuticals people were taking, how those pharmaceuticals change over time. And now that we are quite close to being able to have an electronic interface with licensed producers to get their certificate of analysis, which shows exactly, because when people talk about a strain, it's a bit of a misnomer, because the same strain for two different licensed producers could have a different profile in terms of the active ingredients. And so ultimately, we believe we have to have the actual cannabinoid profile of what people are taking, marry that with ongoing data, patient data and experience, and then we will have a database that over time we can work with researchers and scientists to indicate from a real-life experience perspective. And certainly ourselves as Canada House, we want to take that leadership position in terms of ensuring that we get as much data as possible. But again, we have to leverage real-life experience. Unfortunately, just the nature of cannabis to try to it's great. The more clinical trials that could happen, that's great. But I think we can't just rely on that. We have to do a better job of managing the data that's out there. But 100%, people have to go through qualified cannabinoid educators, medical folks, in order to kind of get onto the right prescription. Because if they don't, then you definitely run a risk of not getting the right results.
Excuse me, just to add to that, how diverse is it? I mean, is every plant different? I mean, does every plant give it?
Thousands of
thousands of
cannabinoid
strains,
profiles,
so-
absolutely. And that's why it's such a difficult thing to study. And we're very lucky here in Canada because we're the first country in the world to create a regulated market where the products coming out of licensed producers are lab tested. There's a certificate analysis that goes with that product. And until we can connect that certificate of analysis to the medical history and the treatment protocol, we won't be able to crack this code. And because it's not a single molecule pharmaceutical, you can't be studying it in conventional phase 3 clinical studies. Right. Essentially, you do phase 3 clinical studies to get to the phase 4 studies, which is real-world tests. Now, this has been brought to market through Supreme Court rulings, so we don't have the need for phase 3 clinical studies, and because it's a multi-molecule substance, we need to study it and approach it differently. And that's what we've invested almost $2 million in developing, is this software platform that manages our clinics and our clients' experience, at the same time collects this data and allows us to see trends between cannabinoid profiles, treatment protocols and particular conditions. And to answer your earlier question, I would never argue that cannabis is a cure for
Right.
PTSD or other conditions. It's no different than any other pharmaceuticals.
Sure.
What makes it different is it's better at treating multiple conditions, and it creates the appropriate mindset for veterans to heal, to reintegrate themselves, repurpose themselves. And I think that cannabis is a much more effective treatment of PTSD and a tool for transitioning out of the military than handfuls of pharmaceuticals. And when guys are in zombie-like states, they're not being self-reflective, they're not understanding what triggers them, and they're not able to improve their lifestyles.
Yeah, no, I tend to agree with that. But I think these questions have to be asked.
Absolutely. And
Okay.
we're glad you're asking them.
Thank you.
Yes, thank you.
We move to second round. I just actually want to follow up on the idea of a strain, and thank you for sort of clarifying it. But I'm trying to figure out how you establish what is the absolutely best combination or best product for a particular individual.
You know, it's a couple of things. It's years of experience. It's sharing those kind of best practices. And so what we say is we want to have the best starting point. So, you know, when antidepressants are being prescribed, I mean, they're typically starting somewhere, then experimenting. You know, we want to have at least a starting point that we think we have prior clinical experience that says it's proved effective. Now, quite honestly, we know that medicine works differently for different genetic makeups. So the same medicine that works for me will work differently for you and vice versa. And so there has to be a bit of a guided journey. And that's why, you know, we have this ongoing relationship between our educators and the patients. And sometimes, you know, they're emailing us sort of daily, particularly in the early days, because there's always going to be a little bit of fine tuning. We think over time in terms of collecting this data, once we actually have the certificate of analysis, and we get a little bit more scientific about it, that will kind of improve the quality of our first recommendation. But so right now it's a combination of using kind of our experience, sharing resources across the company, you know, looking at sort of external results, and then moving forward. I mean, we talked earlier about how, you know, one strain can help with anxiety, another would kind of make it worse. You know, so a balanced one-to-one indica in terms of talking about THC and CBD, you know, particularly on an oil basis, you know, will definitely help people with anxiety. If someone has a high THC sativa, again, indica and sativa, two sort of groupings of cannabis. Within each of those, there's lots of different strains and hybrids between the two. But, you know, a high THC sativa could, in fact, make anxiety worse for someone, right? And so that's just a simple example, again, on, you know, cannabis is very powerful, but if it's not done effectively, you know, it just isn't appropriate.
I would say a lot of it comes down to education and people experimenting with different types of cannabis to find what works for them isn't a bad thing as long as they're educated on how to do it appropriately. And I don't think it's unique to cannabis. I think a lot of pharmaceuticals are administered that way. Does this work? Oh, it doesn't work. Okay, on to the next thing, or it does work. So this isn't unique to cannabis, and I think that people just need to be trained to access it safely, use it appropriately. And I always like to remind people that medical patients don't use cannabis to get high. We use medical cannabis to feel normal and to lead sober lives. So.
I think there's an opportunity down the road. I mean, there's great promise if you look from a North American perspective. I mean, U.S. health insurers are actually paying for genetic testing because they recognize it will get to the right pharmaceutical more quickly. You know, there's probably, we know that, you know, about 25% of the population, how they absorb pain medication is different, and that might actually be an early indication that says don't even try, you know, try something different, because we know that traditional opioids aren't going to be effective for that segment of the population. So I think there's great opportunity as we go further to apply some of that sort of scientific thinking to cannabis as well.
And in terms of I think one of you described it as a journey as you go through that. So if I come into one of the clinics as a patient, particularly for people who are listening, can you explain what the steps are? Because I think you obviously make an assessment.
Right.
And then is there sort of a regular follow-up to see whether it's working?
Yeah, so absolutely. So, you know, people come to us and, you know, if they just want more information or don't even understand the process of medical marijuana, medical cannabis in Canada, you know, we explain that. But effectively, they need to come to us with a physician referral or a very well-documented diagnosis, similar to what veterans would have through Veterans Affairs. In terms of how they're assessed with PTSD and other elements. Based on that, then we indicate to them what medical information that we want, because we want a complete a medical history and certainly all of the drugs that they're currently taking. That is put together, and then patients are scheduled, half hour, 45 minutes with a nurse educator who basically reviews the clinical history. Based on that, asks a lot of questions around prior usage and different elements, and then recommends a particular profile, and then educates people in terms of kind of how to use it. And the reason, generally people are taking oils or vaping, but, if you need a quick a dose of medication, then obviously vaping does that. But there are so many different ways you can take it. And so, some people might choose for economic reasons to purchase dried flower and want to make their own oil. And so, but if you don't do that appropriately, you lose the impact of the medicine, right? So there's a lot of education that needs to occur in terms of appropriately using the medicine. At that stage, then the file is sent to one of our prescribers, typically a physician, who meets directly, again, with the patient, kind of confirms the recommended treatment plan, issues that prescription. And then we work with the patients to recommend particular licensed producers, typically multiple products, daytime use and evening use. We help the patient actually register with the appropriate licensed producers, send the prescription, which is called a medical document, up to the licensed producers, which then enables the person to be able to kind of go home and, as a purchaser, purchase against their prescription through a licensed producer, and that material, of course, is sent to them. Initially, we would do a 3-month assessment, and so they would have to come back for a renewal of that prescription. But like I said, we open the door, and most patients kind of take advantage of that to basically have ongoing interactions with our nurse educators, which I think is really important to sort of fine-tune kind of that process. And so at a high level, I guess that, if that answers your question, is sort of the process that we do, and I think is kind of the appropriate way of handling something like cannabis, which is not the same as a typical prescription drug.
And one of the critical components of our process is the 90-day follow-up, regardless of whether or not that's a renewal. We follow up with that patient, and we take another look at their pharmaceutical use, at their treatments that they're continuing or discontinuing, and as we do these follow-ups, that's how we're able to build up these patient years and understand what's really happening on the ground with these patients.
Well, thank you. I think that's helpful. I have another question, but I'll move my colleagues first in case they have something on second round.
Well, perhaps just a few questions,
Absolutely.
Madam Chair. Okay, thank you. Gentlemen, as I understand, your organizations are part of the Canada House Wellness Group.
That's correct.
And the group has 3 subsidiaries, including both your organizations. It also has another subsidiary called Analysis Technologies, Inc., okay?
Sure.
I understand that's a business that develops technological tools to track the results of using medical cannabis. They're not here today, but could you, you've had contacts with them?
Yeah, we've founded the company, and we've been through Cannabis for the past year and a half, almost 2 years, been developing cannabis patient management software. So we currently run our clinics across the country on version 1.0 of that software. We are almost completed version 2.0, which is a brand new program. We've built an automatic program interface with the industry-leading seed-to-sale software. So as we bring in our patients and we screen them with our nurses, we collect hundreds of data points. When we recommend the treatment protocol and we connect them through this API with their licensed producers, when they purchase from those licensed producers, the certificate of analysis of the product that they purchased pushes back into our system. And this is the first time in the history of the world that anyone's ever been able to connect that circuit. And the Canadian regulated market has been the first place that's ever been possible. And that's one of the main reasons we're here today, is to encourage you to continue the conversation with us and with regulators and Veterans Affairs Canada, because until we can get thousands of patients onto a platform like this, and it's mandated by the regulators that this happens, we're never going to get the evidence that we need. And this is the key to the puzzle. It's going to take us years to collect the data and truly understand it, but if we don't start now putting it on this type of platform, we just push that timeline out further.
Just to add to that, because for clarity, again, it is the software, as Riley indicated, that our clinics use. I actually, in the short term, I have leadership accountability for analysis in addition to Canada House Clinics, so all 3 are in some ways kind of represented today. And the market has sort of seen value in that, so we do have clients, and it's a global market, as cannabis and medical cannabis particularly does kind of grow in different parts of the world, and it's the right tool for that type of industry.
The software, it really interfaces with patients, physicians, and producers, and collects that data in a usable format.
Madam Chair. Mr. Kroon, in your presentation, you mentioned that veterans on traditional medications are not able to sustain normal relations with spouses, children, and friends. So my question is this: in your experience, does the use of medical cannabis by veterans increase or decrease the ability to function on a daily basis with family and friends?
Our veterans overwhelmingly indicate that that has a significant impact in terms of their ability to have useful and productive relationships. Again, to have compassion for, their spouse, their children. There are examples where, our clinicians in a particular clinic would first meet a veteran coming in, who might not sustain, eye contact, is really not, participating in conversation, clearly seems quite withdrawn, is quite stressed. You can tell that they are in distress. And then, 3 months later on that renewal, they're coming in, they're engaged, they're happy, they're hugging folks kind of within the clinic. And so many veterans will, and certainly spouses as well of their partners, will describe a significant change. And again, we're not saying that it is the cure. It creates the circumstances in which people can do the self-reflection. And so, when you think about cognitive behavior therapy, talk therapy, other elements, you have to be in a place where you can process that information. If you're not sleeping, if you have nightmares, if everything, people might trigger on a number of different things. And, if you can't be able to kind of process and think about what you need to do to kind of move your life forward, it's not going to be effective, right? And so it creates the conditions in which people can do the work that's required in order to transition. And, as I understand, Riley is a veteran, I'm not, that even without PTSD, it can be a difficult transition from military life, if that's all you've known for many years, into civilian life. It's a completely different world. And that creates a certain amount of stress, without even PTSD being involved. And so when you throw the two together, it's really asking a lot. And, it's challenging for folks who are diagnosed with PTSD while they're still serving. And quite honestly, it's a long and difficult process. And it's probably even worse, before they actually fully leave the armed services and are then outside. So, yeah, absolutely, the overwhelming evidence in terms of the veterans that we work with is that it has a very positive impact.
What about impairment? Do patients who consume medical cannabis manage to drive or go to work without being impaired?
Yeah, I think the opportunity for impairment is always there, just like it is with any prescribed medication. So people need to be educated if they've new to it or they're intoxicated, they shouldn't be behind the wheel. I would say that most medical users who have been using medically for a while and understand their dosages and that absolutely, like I said earlier, they're not using cannabis to become impaired, they're using cannabis to feel normal. So I would not, although the possibility is there, just like any other prescribed medication, I don't think that impairment in medical patients is something that's rampant or common.
And again, part of the fundamental education process is people understanding, if you're vaping, the effect is 4 hours. If you're taking an edible or oil, it might be 8 hours. We're generally across the entire patient base are, encouraging kind of a lower THC during the day, more CBD oriented. If they do benefit or need higher THC, trying to do that in the evening. So again, it is part of being responsible in terms of the medicine.
A final question, Madam Chair?
Absolutely.
Yes. With Veterans Canada, the magic number appears to be 3 grams a day. Mr. Kroon, my understanding is that on your website you offer a second-level assessment.
Correct.
That enables veterans who wish to use more than 3 grams of cannabis per day to apply to VEAC for recognition of quote-unquote exceptional circumstances.
Correct.
So could you describe in more detail the second-level assessment that these patients undergo, and what do you mean exactly by exceptional circumstances?
Sure. So let me start, and then Riley can chime in as well. First for clarity, we are leveraging a process that Veterans Affairs set up, and we are executing it on behalf of veterans to assist them to kind of navigate through that process. We have a very talented psychiatrist who basically will, there's a fair bit of work that we do in up front in order to kind of assess, is this someone an appropriate candidate for that? Because we understand some of the guidelines that Veterans Affairs kind of puts on that. And, quite honestly, I would say most veterans probably are managing quite well, relative to, the 3 grams. If you look at medical marijuana use kind of across the industry, it averages probably 1 and a little bit more kind of grams per day. But certainly there are folks, and when you look at the extent and severity of PTSD that a veteran has gone through, I mean, most of us can't imagine, the experiences that they've gone through. Certainly those are the folks who often do need a higher dosage. So effectively, we facilitate that process in terms of the required assessment. We make a determination that they are a good candidate for a second level assessment. We set up a session with a psychiatrist who validates their diagnosis, validates, how they're performing at the current level. Again, the prescription has already been defined previously at an appropriate dosage. The difference here is that, if the prescription was for 5 grams, Veterans Affairs is only funding 3. And for some folks, cannabis is not inexpensive, right? If it averages out to, $10 or so in the general sort of market. And so for some veterans, that extra just simply, isn't possible for them. And so the psychiatrist is validating that it is an appropriate prescription based on their diagnosis, and then is basically indicating to Veterans Affairs that, in our view, it is medically necessary for that person. Veterans Affairs would ultimately make the final determination on that second level assessment. If it is successful, and then their coverage is extended beyond the 3 grams. So.
Yeah, I think the cutbacks to 3 grams was an appropriate step to have taken. I think that it did initially present some challenges to some veterans in accessing their medicine, but I think as everything's shaken out, we have these second level assessments available to those veterans who need them, again, we're grateful to Veterans Affairs Canada to offer that coverage. I don't ever want you to think that we are encouraging people to get second level assessments to get coverage above 3 grams. The only time a second level of assessment would ever be offered is if that person is already prescribed and utilizing more than 3 grams. Then the second level assessment would come on over top of that to help obtain them coverage for that additional medication.
What proportion of your patients require more than 3 grams
I would say
of cannabis a day?
Of approximately the 2,300 veterans that we have, I believe we have probably approximately 500 to 600 rough numbers that have utilized second level assessments.
How many grams a day?
That would range typically between 3 and 10 grams a day, depending on the patient. Often the patients who are using more medical cannabis have compounded conditions. So they have PTSD as well as suffered a blast injury, so they have chronic pain issues as well, and they're often consuming that medication in the form of oils or edibles for pain treatment.
Thank you, Madam Chair.
Thank you. Senator Richards.
Yeah, thank you, and I got my notes here and I can't read them, that's the way I am, but how many joints is 3 grams? Like it's just
3 grams would be approximately 5 or 6 joints.
5 or 6 joints, okay, yeah. So I'm just thinking that if a person, you're doing research and data, and with these veterans, and veterans aren't the only ones that suffer from PTSD. A lot of people do.
Absolutely.
And I came from an area that had a lot of drug use as kids and everything that went on around me, and I saw it, and I saw that there was a lot of damage done. And we all know that.
Yep.
We all know that. But as far as your research goes, if a person is self-medicating outside the Veteran Affairs facilities with other marijuana, how does that figure into it? And can you know that? Can you know if a person's doing that? Because I'm sure some will be doing it, and it might screw up the data and the research. And I'm just wondering how do you keep tabs on that, or do you, or do you know anything about that, or?
Let me start, and then, so certainly part of our intake process, and it's certainly actually a fairly fundamental aspect of a second level assessment as well, is to understand. We ask those questions in terms of not only what prescription drugs people are using, but, in terms of alcohol consumption, and other sort of illegal drugs. Unfortunately, before they start cannabinoid therapy, often that can be a traditional way of coping, right? Unfortunately. And so certainly that does factor into kind of our advice for people. And the good news is that, and again, I made the comment of, unfortunately, sometimes the media kind of talks about a gateway drug, but we think it's an exit medicine, right? I think from a harm reduction perspective, it's a very effective way of transitioning away from some of those dependencies into a much healthier circumstance. And so certainly, it is important, and it's very fundamental to the second level assessment process in particular, since you were asking about it, that we understand everything that's going on. Obviously, if you're talking about self-medicating in terms of cannabis use outside of the medical piece, I mean, again, we try to understand our clients as best as we can. And, in terms of our message to the general public is that, it's very hit and miss, right, in terms of if you're trying to self-medicate. And so it just is very strongly recommended to go through a proper coaching process around it.
Yeah, I think it's a great question, and it's one of the challenges that we face. So we screen for drug-seeking behavior, but if we discover through that screening that a patient is using illicit substances or other substances outside of a medical kind of regime, is that a reason not to prescribe? Because potentially this prescription can help them lower the use of those drugs. So it's something that it's a double-edged sword, I think, and we monitor it closely. And if we do turn patients away, we do cancel authorizations if we discover people are accessing illicit drugs or illicit cannabis outside of the programs. So we are cognizant of that. Our nurses and the people at our clinics, we do take action if we see things that are inappropriate. We absolutely do.
Yeah, I'm not trying to be self-righteous over this. I'm just asking the question for the help of the veteran himself or herself. That's why I'm asking the question.
Absolutely, yeah. And I think that's where not only have we invested in our software, but we've invested in our not-for-profit, the Post-Traumatic Growth Association. And there's basically 8 spokes of wellness that's based on, and that's sleep, diet, exercise, financial health, relationships, all these different things that veterans need to find balance in their lives. And that's why we believe that cannabis is a great treatment, treats those conditions, but it's going to be in those peer support groups and in communication with their peers that things like these issues are going to be identified and guys are going to get the right direction. And we believe that, I think we'd all agree that the people you associate with and the actions and the intents of those people is going to have a lot of influence on where you go and what paths you take. And we try and have a very strong, positive culture in these peer support groups and really encourage people down the right path. And we think that that's a very important component. And if, that's another place we would like to see potentially some funding and more support is around programs where you have accredited facilitators and you have an approved program. There should be some funding available to, we fund those at great expense, and it would be because we know how critical it is. And it'd be great to have support with these programs that we know work and pair well with the investment that Veterans Affairs Canada is making in cannabis.
Question reminded me of one point that I think is interesting in the sense that, we very much see ourselves as kind of part of a holistic approach to the patient. And so, whether you're talking about illicit drugs or even other prescription drugs, I mentioned our overall process before and that, our preferred model is a referral from a physician. I wanted to kind of clarify that in our process, we also then communicate back to the referring physician to indicate this is kind of what we're doing with the patient. And frankly, we would love, and hopefully legalization begins to sort of change the attitude of kind of more and more doctors. We would want to sort of be part of a health team working on a patient and share information with their referring physician in terms of kind of what we're seeing, what we're recommending, so that we can kind of work on it together. Because we know that one of the problem, I spent a lot of time in terms of different healthcare companies. One of the biggest issues in terms of healthcare is the silos, right, that occur within the system. And certainly from our perspective, we don't want to be a silo. We want to be integrated in with everyone who's the circle of care around that patient is where we want to be part of.
Okay.
We need to involve the care teams of these patients, and I think we're you're maybe not seeing the reduction in pharmaceutical use that you would like to see in correlation with the cannabis use. I think a lot of that has to do with the silos, like Alex said, and a lot of veterans can't go to their prescribers or their treating physicians and tell them that they're using cannabis because they will not deal with them. And I think until we almost mandate that they drop the stigma and work cooperatively with the cannabinoid therapy specialists, then the care team's working collectively to either reduce pharmaceutical use or reduce cannabis use, but it has a mandate to reduce drug use, period.
Right.
Yeah.
Okay, thanks a lot.
No problem. Thank you.
Just want to make a final comment, Madam Chair. Well, thank you for your presentations, and I think the key is medical follow-up. Unlike veterans, the problem with recreational marijuana users is that they don't have a follow-up. And, that's the reason why they get themselves into trouble and develop physical and mental ailments. Thank you for your presentation.
Thank you.
Thank you so much.
On behalf of the Subcommittee on Veterans Affairs, first, Mr. McGee, let me thank you for your service on behalf of all Canadians. And I want to thank you both for your presentations. This has been for us a very interesting hour almost, and we're deeply appreciative for your presence here, so thank you. And the committee will adjourn.